dubious. My name's Steve Samuelson. I'm an orthopedic surgeon in Montgomery, Alabama at Southern Orthopedic Surgeons. I've done work comp there for almost 22 years total, 7 since residency. But anyways, today I'm your medical moderator. This is my first time, I guess, being to this conference, so I hope I do this right. Let me know if I'm doing it wrong. Our first speaker today comes from Mississippi, small town, Tylertown, Mississippi, and she did her medical school at Jackson there in Mississippi after graduating from University of Southern Miss. She also stayed there, did her anesthesia residency as well as pain fellowship, and now is a medical director at IMC Comprehensive Pain Management Clinic. And she's going to talk to us on a topic that not many doctors completely comprehend or understand. So I'm very excited to hear her speech. And if hopefully we have a little time for questions afterwards, and I'll help moderate that. So without any more delay, I'll let her speak.
Thank you. Thank you. They asked me to give the speech and I was like, oh yeah, okay, I can do this. So comprehensive pain, you know, we see all kinds of pain. We do neuropathic, we do chronic. I try to keep from doing a whole lot of acute, but occasionally we get acute pain too. So, but complex regional pain syndrome is one of the ones that we're always like, oh goodness, when we get a referral for that. But because it is a hard thing to diagnose and treat. So here I go. Putting a rope around complex regional pain syndrome. And I am double board certified in anesthesiology and pain management at Mobile Infirmary. That's where I am now. And next we'll have the table of contents. And then next is, I wrote this because I was looking online for patients. One of the things I came up with is this patient who has diagnosed in the 80s with complex regional pain syndrome. And he wrote this: imagine going through your daily life where everything you touch or that touches you, where most every noise around, from a passing car or plane to children playing, causes you pain. And this guy has written a lot of forums about complex regional. And I've kind of read through because I was wondering if he actually had it or not. And he actually does fit all the criteria. So, all right. So complex regional pain, it was formerly known as sympathetic dystrophy, RSD, reflexive sympathetic dystrophy, and it is a neuropathic pain condition where the cause of the pain is due to hyperexcitability of nerves. The formal definition of neuropathic pain is pain initiated or caused by a primary lesion or dysfunction in the nervous system. There are two types. Type 1 assumes that there was an injury to a nerve, but there's no evidence of major nerve damage. Type 2 has evidence of the major nerve injury. And then population-based estimated incidence is between 5 to 26 per 100,000 per year. And it is more common in females to males. The most common inciting events leading to are fractures, crush injuries, sprains, and surgery. The clinical manifestations of it are pain, typically the most prominent feature, and debilitating. It can be described as burning, tearing, and it can be felt deep inside the limb. It can be continuous or it can come and go. Sensory abnormalities are common, and they include hyperalgesia, allodynia, or hypoesthesia on examination. Motor symptoms can be seen in approximately 2/3 of patients. Impairment usually is manifested by reduction in muscle strength. Limb movement may be limited by edema, pain, or contractures. Autonomic changes, such as differences in skin temperature, skin color, sweating, or edema, comparing the affected side to the unaffected side, are common symptoms of CRPS. Trophic changes affecting the connective tissue include increased hair growth, increased or decreased nail growth, contracture or fibrosis of the joints, and fascia and skin atrophy. So there are two criteria. The one I use is the Budapest. It's more sensitive and specific. So it is the presence of continued disproportional pain from the known inciting event, must report at least one symptom. So a symptom is something the patient is actually reporting. A sign is something you see. So it has to have at least one symptom in 3 of the following 4 categories. So for sensory, hyperesthesia, extreme sensitivity, allodynia, pain due to something that doesn't normally cause pain, vasomotor, temperature asymmetry, changes in skin color, pseudomotor, which is the autonomic system changes, sweating, edema, motor and trophic, decreased range of motion, motor weakness, trophic changes of skin and nails. And then number 3, must report at least one sign, so what we see, in 2 or more of the following categories. With the sensory, hyperesthesia to pinprick or allodynia to touch, vasomotor with the temperature, pseudomotor, we look for swelling, sweating changes, and motor, of course, decreased range of motion. No other condition that would otherwise explain the degree of pain or dysfunction. Oh. Okay, this is the other International Association of Pain criteria. It's not as good as the Budapest, but it's the presence of it initiating noxious event or reason for immobilization, disproportional pain, allodynia or hypoalgesia from a known inciting event, sign or symptom of any evidence showing edema, skin changes, blood flow, or abnormal pseudomotor activity, and no other condition can otherwise explain. I already said that the Budapest is more sensitive and specific. The diagnosis of CRPS is based upon clinical features as determined by the history and physical exam. So this is a clinical diagnosis only, unfortunately. Symptoms usually start within 4 to 6 weeks after limb trauma. There is no gold standard test or method for confirming the diagnosis. There are sensory testing with pinprick and sensation, and then autonomic testing for temperature. There is a 3-phase bone scan that's valuable for detection for CRPS. It can detect abnormal bone metabolism. It shows increased tracer uptake, and that could confirm a diagnosis, but a negative one does not rule it out. So there's a lot of question about should it even be done. If it's going to be negative, it doesn't rule it out anyway. And there is no clear role for MRI or CT when you're suspecting CRPS. Okay, so the 2 types. Type 1, formerly known reflex sympathetic dystrophy, is seen without any major nerve. 2 of the 4 criteria must be satisfied, and this one represents about 90% of the cases. The presence of initiating noxious event or cause of immobilization, continued pain, allodynia or hypoalgesia, disproportionate to the initiating event, evidence at some time of edema, changes in skin blood flow, and pseudomotor activity. Diagnosis is excluded by other conditions. And then type 2, this one is seen with a major nerve damage. Causalgia is the other name for that. And is the presence, all 3 criteria have to be met with this one. And this is the presence of continued pain, allodynia, and hyperalgesia after a nerve injury, and evidence of edema, skin changes, pseudomotor activity, and diagnosis is not excluded. The consensus definition of CRPS is as follows. CRPS describes an array of painful conditions that is characterized by continuing regional pain that is seemingly disproportionate in time to the usual course of a known trauma or lesion. A consistent finding in both types of CRPS is a discrepancy between the severity of the symptoms and the severity of the initiating injury. In addition, symptoms have the propensity to spread in the affected limb in a pattern not restricted to the specific nerves area innervation. Now, notice I said in the affected limb. Very rarely do we see it go to the other limb. So, in addition, symptoms have, we already talked about that. CRPS is characterized by intense burning pain with resultant hyperalgesia or allodynia. It may be associated with local edema and autonomic involvement, skin changes, sweating, increased, decreased temperature. Also tropic changes in the skin and nails is seen. Many questions concerning the pathophysiology of the syndrome are unanswered. The main principles remain at the core. Abnormalities in the somatosensory and sensory pathways, as well as the sympathetic nervous system involvement. But I did everything I researched, even the most up-to-date stuff. The pathogenesis is unknown. Proposed mechanisms involve both peripheral and central nervous system and include classic inflammation, neurogenic inflammation, maladaptive changes in pain perception, pro-inflammatory cytokines, central sensitization, and sympathetic nervous system. Genetic factors, autoimmune, are all thought to influence the development of CRPS. We already talked about it's more common in females. Initiating events most commonly are bone fractures, sprains, and trauma. Outcomes are worse in patients with upper injuries versus the lower injuries. Worse outcomes are also seen with chronic, or we call it cold CRPS, versus the warm or the acute. Other risk factors that contribute to the development of CRPS are age, workplace injury, and type of injury. The age range is 16 to 79. It's higher incidence in older population. Patients with motor nerve damage are at risk for CRPS, or more at risk than the patients with sensory. Fracture is the most common initiating injury. I highlighted this because this is important to y'all. The incidence of job-related injuries leading to CRPS is as high as 76%, which may indicate a psychosocial or secondary gain component in reporting this pain. Studies do show that it can run in families, so there may be a genetic component to it. All right, clinical features: pain must be greater in proportion to initiating event, must have at least one symptom in the 3 categories. We already talked about that, and at least one sign must be present in 2 or more of the following. We talked about those already. Moving on to treatments. Treatments, it's best if it's multimodal, multidisciplinary. The predominant modalities are physical therapy, medications, and interventional procedures. Physical and occupational therapy are the mainstay for CRPS to restore function and strength. The pharmacologic therapies are membrane stabilizers, gabapentin and Lyrica. They work great for neuropathic pain, and they also work great for complex regional pain in most cases, and they are considered first-line therapy. NSAIDs and corticosteroids have been used for the acute inflammatory process after the initiating event. So, if you think about it, when it first happens, corticosteroids and NSAIDs are great, but the problem with fractures, a lot of orthopedics don't want to start that if they're trying to heal from a fracture. So antidepressants such as tricyclic antidepressants and selective serotonin norepinephrine reuptake inhibitors have been used to control neuropathic pain and are also thought to be helpful. A recent study showed that the combination of gabapentin and nortriptyline was more effective than either of the medications used alone. The studies on the effects of opioids directly on CRPS are lacking. The problem with neuropathic pain is it is one of the most painful conditions somebody can have. So the doses of opioids that you would have to use to reduce that would be so high that the risk would not outweigh the benefits. So they are not considered first-line treatment. Ketamine, which is an NMDA receptor antagonist, are thought to be a major part of central sensitization that occurs in CRPS. The topical form has been shown to decrease allodynia and hyperalgesia in response to pinprick. And they also do, where I trained at UMC in Jackson, we used ketamine infusions, and that worked actually pretty good. When I came to Mobile Infirmary, we don't currently do it just because we don't have the facilities to do it. You have to have an RN, and I mean, I could administer it myself, but I would have to sit there while the patient's having it. It's just not, but we are looking into possibly doing this, but there are clinics around that do it. The most common one I send people to around our area is there's a ketamine clinic in Pensacola that does it. So, and that has helped people because they do an IV and then they give it IV and they give over an hour and it actually does work. So topical lidocaine creams and patches are also useful. Bisphosphonates can be used to decrease osteoclastic overactivity and can be pain-reducing effects. It is felt that by decreasing the bone reabsorption at the site of inflammation in the affected limb, it will also decrease the pain. Interventional treatments, the most common sympathetic nerve blocks, the stellate ganglion for the upper and then the lumbar sympathetic for the lower. Although sympathetic nerve blocks provide significant reduction in pain by blocking the sympathetic pathway, the greatest limitation is they only provide short-term, not long-term. This form of therapy should be used to provide enough relief for the patient to be able to perform physical therapy and exercises for functional restoration and multidisciplinary therapy, but it should not be used as sole therapy alone. Usually we do this for people that can't do physical therapy. They're hurting too bad. So we'll do a sympathetic nerve block just to see if they can get enough relief to do the therapy over the next 4 weeks. Spinal cord stimulators have been used to treat some with CRPS, but the studies are inconclusive and more studies are needed to prove that they are helpful for the vast majority. Intrathecal baclofen and zonacotide, they have been used, it has been examined for treatment of CRPS, but they have a lot of side effects, so they are not recommended. If coexisting depression, anxiety are present, cognitive behavioral therapy is recommended. And it's known that with depression and anxiety, it will make pain worse. So if you treat that, it will help the pain. Prognosis. It's uncertain with highly variable rates of poor and favorable outcomes in different studies. A substantial proportion of patients have some degree of prolonged disability. A study of 102 Dutch patients followed over 5.8 years since onset showed 64% had ongoing CRPS diagnostic criteria. Patients consider themselves recovered, stable, and worse due to progressive disease in 30, 54, and 16. So of those patients, they consider themselves recovered 30% of the time, stable 54, and then worse 16%. Patients resumed their previous work completely, then resumed work with adjustments or when able to work. And so previous work, they 41% resumed it and then resumed work with adjustments 28, and then were unable to work 31%. And this is in a Dutch population, so I'm not sure of how they're if they have workers' comp or, I'm not sure on that, but litigation and work-related compensation issues are involved in a substantial proportion of cases of CRPS, with work compensation being 54%, with cases reported at tertiary pain management clinics. The recurrence of CRPS is not uncommon. Estimates of recurrence are approximately 10 to 30%. Vitamin C has been suggested as a low-risk intervention that might accelerate fracture healing and limit excessive soft tissue injury via antioxidant mechanisms. These are some pictures of true complex pain, complex regional pain. So you can see the color changes, and also on the picture on the right, you can see, the foot is turned in. It's obvious. And then these pictures at the bottom, this is actual patients with it. And usually when I tell people, when you see it, you know it. And it's not always the case, but it's usually pretty prevalent. So it's not one of those things that, they look normal and, oh yeah, they got something. There should be some abnormality. So it's quick and short, sweet. But if y'all have any questions, I'm happy to answer them. And if you have any questions you want to email me about, I'm happy to answer that too. So
I have a question.
Sure.
So the patient who comes into us with an ankle sprain 4 months out, still hurting, can't touch their ankle, they can't walk, they don't want to go back to work, they have pain that's allodynia, they complain of hyposthesias. But when you look at their exam, they don't have much swelling or obviously much, physical findings. Y'all seen these patients before? What do we do?
Send to me.
And so what would your workup would be? Do they meet the criteria?
Yes.
Okay.
Seeing that sometimes when I see orthopedic, if they get the diagnosis of complex regional pain, the orthopedic gives it to them and then they send it to me. It's hard for me to go back because then I'm like, oh, well, they didn't know what they were talking about.
Right.
You don't want to say that, right?
Right.
So you're trying to I'd rather than just, in their notes, maybe put, we're not unsure of the diagnosis, possibly neuropathic pain, possibly complex regional, but don't put the formal diagnosis on there. Because once you do that patient's head and then they're like, oh, well, no, this is, did my surgery and been treating me. That's what they said I have. And it's hard to undo that.
So I was trained long ago before it was named this. It was back when it was RSD and just in causalgia. But one of the hallmarks of our understanding of treatment was send them for a stellate ganglion block or a lumbar plexus block. And if they got better, that would sort of help us determine that the diagnosis is real. Do you use it?
No, we do not use it for that because now we've proven that it's not all sympathetically related. Those blocks are just for sympathetic related complex regional, and there's a bunch of complex regional that is not. So those blocks wouldn't work, but that doesn't mean that they don't have it. Okay.
But if they do get improvement by it, does that confirm that they have it?
No,
not either. Okay.
It does not.
So it just means they have some sort of
sympathetic issue, but it does not, like I said, it is not one of the confirming, the only confirmation, it's the history and physical exam. That's the only way you can confirm it. No tests, no procedure, no nothing can confirm it.
Anybody have any questions on the floor? Yes.
I'm sorry, I couldn't hear.
I think her question is insurance authorization for ketamine IV.
So, and that's another thing why we don't use it in Alabama. So Blue Cross Blue Shield does not cover it in Alabama. In Mississippi, they did, and that's why we used it there, but in Alabama, they don't. So that was another reason I didn't, but in different states, they do. So like I said, Mississippi, they do. Florida, they do. It's just Alabama, they don't. So, but I've personally seen people get better from ketamine infusions, and it's a lower risk type procedure, and it's usually done once a month for about 6 months, and the patients do have some improvement. So I don't know, what they charge, because at the time we were doing it, I was in fellowship. So I don't know, when I worked for a hospital, so I have no idea. But there is the closest ketamine clinic to us that I'm aware of in Mobile is Pensacola.
I think one of the keys to her treatment slides is the multimodal approach.
Correct.
And as we discussed, just the blocks don't work. Just ketamine probably alone doesn't work. Nope. If they do have the personality disorders, they need cognitive behavioral therapy, because Correct. You can almost see a patient when they come in by just their affect that they're really anxious or depressed about it. And if they're not getting treatment for that, then they're probably not going to get better. Correct.
And a good psychologist or psychiatrist can usually help sort out, what is the motivation, for these patients too. So,
and sometimes convincing patients that they need that, if they're hard workers or whatever, can be difficult, right? Because
they see to go see them because they're like, you think I'm crazy? No, sir. No.
But being 24 hours a day, having pain all the time,
right. That can make you. That's what I always tell people is pain can make you. It can cause anxiety. It can cause depression. So that's what we're treating you. We by no means think that you have any kind of problem. We're just trying to treat you because we know you're anxious. We know you're depressed because of this. So,
does anybody else have any questions? Let me see if I can extend this. We have another half hour before our next.
Oh gosh, did I make it?
I don't know. I don't know if
I'm sorry.
I don't know if I can ask a half hour's worth of questions, but maybe we can. So the patient who is multi trauma and comes in and they won't move, they're swollen, and they have physical findings that are similar, but the trauma actually could cause the criteria that, initially. So, they have terrible swelling, terrible pain. How do we sort out maybe the person who might be seeing this acutely, but versus the extent of their trauma is causing most of the symptoms itself? Do you have to wait? Is there a certain time?
Well, if you look at usually it develops within the first 4 to 6 weeks, but it's hard because patients are recovering. So I don't think you can really make a diagnosis till it's been a couple months, because that way they've had time to heal from whatever injury, and then you kind of see where you are. But that doesn't mean you shouldn't start. Of course, y'all are pretty good. Orthopedics are pretty good about starting them in therapy as soon as they're able. And the vitamin C actually came from the Orthopedic Society's recommendations. They start that pretty early too. So I think that is helpful. So
yeah, I think I don't know if you didn't talk a lot about prevention. I saw the slide, but I think the immediate treatment for trauma injuries, listening to the patient, making sure you're identifying what their problems are and addressing those, probably has a better outcome than the one that's getting delayed treatment. And sometimes work comp gets a beef because of getting access to care, delay, the authorizations, and then that I think that could lead to it a little bit more if someone's having like a fracture that's not stabilized or needs surgery or something that's not recognized and not treated. There's probably a slight increased risk of developing this in this work comp population.
For sure. It needs to be. And I think, usually most orthopedics are pretty good about catching it and starting treatment, like to try to prevent, because nobody wants that nobody wants to have to deal with complex regional. So they're
Right.
pretty good.
One of the reasons most of the orthopedists go into orthopedics is because they see an injury, we fix it, people get better, and they go on. Okay. When they're not getting better, not going on, and we do have that patient in work comp a little bit, right? The patient that doesn't get better, whether it's because they don't want to get better or because they have a condition that's not allowing them to get better. Identifying that quickly is because we don't want to see that patient in our clinic not getting better. We want to figure out why they're not, how we can help them. And it sounds like you have a good way of helping them. So we appreciate you coming today. Does anybody else have any other questions for her? Yes, we got a couple more. Good. What's your question? Oh, we have a personal question.
I like personal.
She wants to come down here and look at a phone image of somebody. Oh, ouch. Ooh, I don't know if I can get that up on the screen. Is there a HIPAA involved in this?
She recently lost one toe and now the condition's getting worse. And she's complained for a long time that she has no sensation in her feet at all. Do you think that will kind of be?
It's hard to say. I'd need to see her to make it. Is she seeing an orthopedic?
No, she's just seen a foot doctor.
Like a podiatrist?
And they
any specific question?
Yeah.
Got a staph infection in that, and it's spreading out. So.
Yeah. Because if she's got swelling in it, which it looks like she does have some swelling, that'll affect sensation. Make her,
But for a long time now, I think it's 5 years, she's like, has no sensation in her feet at all. You feel her both, she don't feel any.
both feet.
Both feet.
See, and that wouldn't be.
Y'all be thinking of
complex,
some more questions for her so we can
be.
keep going
That's
here.
more of like neuropathy. Is she diabetic?
Yeah.
Yeah, so she's probably got diabetic neuropathy, but I would tell her she probably needs to see an orthopedic surgeon that specializes in feet,
Yeah,
like a foot and ankle. Yeah, instead of seeing podiatrist.
So I think the topic is a swollen foot that's got some dystrophic changes. What do we do? I
would
think
tell her
she's recommending send them to an orthopedic doctor.
Because podiatrists are great, but when you got something like this, especially with a diabetic, she's not going to heal good. She needs that vitamin C too. To help.
So we do have another
She makes
question
sure
from
she's
the
taking
floor,
lots
and
of
that
vitamin C.
was
But
something I don't know anything about, so I'm going to have to ask this expert about.
You're welcome.
So the other question from the floor is, what would you do if you were referred a patient who by a psychiatrist thinks they have PTSD and they are ordering a stellate ganglion block?
Oh gosh. So I have gotten the most of those recently. Actually, it's not the psychiatrist per se, it's patients calling in, like veterans. because somebody posted something somewhere about that it can help post-traumatic stress. And I'll meet with them and I'll talk to them about it. Because I've read some studies where it could help, but the problem is insurance. Insurance is not going to pay for it. So, unless you've got some kind of, I mean, work comp pay, but as far as private insurances, even the VA, they're not going to cover that just because there hadn't been enough studies, research out there to show that it actually helps. So as far as me, I'm happy to do it. It's just, it may not be covered. So.
Have you had any success doing it with anybody?
But I have, all honesty, I have never done one for PTSD. But I've read about it because I had all these veterans calling me and I was like, am I missing the boat by not doing this? Like, what is the deal? And so, and I did start, actually, Cleveland Clinic is doing a lot of them and they've shown some studies, but they haven't published them yet. So that, doesn't really help us because insurance is always a delay. So you're going to have the studies, you're going to publish them and then they'll approve it or disprove it. But right now it's not approved, like I said, so.
Do we have any other questions?
Or anything about pain. If y'all have any questions about pain, I'm happy to answer any kind of chronic pain questions. Not complex regional pain related. Because I will say that is probably one of my hardest diagnoses that I see is complex regional.
It reminds me a lot of the rheumatologic diagnosis where you have all these check boxes and everything and some of their gray areas and how to
I know
hit every one of them is hard.
Because I've had patients too come to me and when I walk into the room, I get a lot of information just by walking into the room. So one time I walked in the room and I always knock, but I didn't knock that time. And I walked in and I saw the patient exsanguinating their arm. And I was like, oh, what are you doing? It's one of those things that sometimes, and with y'all, sometimes you're in the room and sometimes you're not. So, depending on where they have attorneys or whatnot, but I mean, that does happen. I saw it. So
yeah, so that patient has a problem, but it's not the problem you were referred with, right? So how do you manage that?
I mean, documentation. I documented and I just documented what happened. And I was like, oh, I failed not prior to going in the room. That was my bad. But I also called them trying to sanguinate their arm. So
yes.
What's the level of business you put on the visibility of the study? So you mentioned that, when you see it and show those pictures of the swelling and things, I've seen cases where they're diagnosed and it's just not visible.
no, it has to be. Remember, because it has to have, you have to have the symptoms, which is what the patient reports, and the signs, which is what we see. If they don't have anything, nothing is seen, no temperature, no nothing, then they ain't got it.
Fair enough.
I'm pretty straightforward too. I don't know if y'all probably can tell about me. I'm pretty by the book and straightforward. So.
Do we have any other questions? We do. We have a few more.
Oh, thank you.
A homie.
Yes. I think they work great. I tell people that it's about a 50% reduction in pain. So what we usually do them for, or when I went through, what we originally did them for is people that had like post-laminectomy syndrome that have had, 3 or 4 surgeries and nothing helps. I've had, every kind of epidural or selective nerve root block, radiofrequency ablation, nothing helps them. They've tried everything and stimulators are a last resort. Interestingly, and this is sad for me to say, because I really wanted the stimulators to be the next greatest thing. But their whole goal was to keep people off of opioids, to keep people off of long-term medication. In my opinion, do they do that? No. Unfortunately, now they may be able to decrease the amount that they take, but I so far have not put one in and they've come completely off of medication. And I really hoped that they would, but the thing is, I mean, the body, gets used to whatever it feels, right? So, you know, those stimulators are like TENS units. So we implant the epidural space. So that vibration, the body gets used to it. So they do have an application that the reps will meet with them every 6 months and try to change the settings so the body doesn't get too used to it to where it doesn't work anymore. But it still does. So it doesn't, like, first year works great, but then year 2, year 3, year 4, it's not working. We're changing settings, all this, and it's just not. But I do think that I'm not saying that they don't, because they do help. They do. It's just, if you're looking to get somebody completely off of opioids, I don't think it does that, but it does get them down on the dose. Now, if you have, and it all depends on patient motivation. I think that if somebody was really motivated and they were like, I do not want to be on this medicine, I want to go back to work, I wanted a true patient that wants, I think it would be a great shot for them, because it could. It's hard with work comp, especially because, not that people don't want to go back to work, I'm not saying that, but you know, it's just hard because a lot of times they're not looking for, oh, hey, let me just get back in there. But you know, if they did, especially in y'all's, and they really wanted something, I think that would be a good shot at it. So I would try to go to somebody that would I'm not saying me, but just somebody that does like a multimodal too, that will be honest. Because there are some people that I've seen that's all they do is stimulators. And that's hard. You know, if you're just putting stimulators, yeah, or people that just do medications, like what, that's not comprehensive. You know, you want to see somebody that's comprehensive, that does everything, so they can make sure, because sometimes I get a evaluation for a stimulator, but the patient's never had an epidural ever. And I'm like, well, we haven't really tried anything else, because the epidural may work for 6 months to a year, you know, and why would, because a stimulator has to be surgically implanted. So it is a surgery. So if you could avoid doing that, you know, by trying other things. Now, sometimes they get to us and they've already tried everything. That's great. Then it's easy. But, you know, if they haven't, it just needs to be somebody. But if you send them to somebody that's all they do is stimulators, they're going to get a stimulator, whether they need it or not, whether they've tried other things or not.
Go ahead.
So and actually, you know, it's been legalized in Alabama by the government. It has not been approved through the medical board yet. They're getting it together. It's not been, physicians have not been given the A-OK to go through with it yet, but it's going to happen. Mississippi's already doing it. Florida's doing it. I think it could be good. I have several friends that practice in Colorado, and I reached out to them and I was like, hey, what do you think about this? And they were like, oh, yeah, it's great. But if you do that, you're not going to be on opioids, right? It's one or the other. And so my friends in Colorado said, when it first happened, everybody wanted to switch. They're like, oh, yeah, no, that's fine. We just want to do the medical marijuana. We don't want opioid, because they made them pick there too. A lot of them decided that is not what they did, and they went back to opioids. So, you know, you know, honestly, I think that probably medical marijuana would be better for my honest opinion about it. But looking at what happened in Colorado, she said a lot of her patients went back to opioids and got off the medical marijuana because they said it wasn't enough. Or they had to use so much of it that it made them not be able to function. Because I think that, and that's hard for physicians, because they had, Mobile and Fern kind of was like, are you going to do this? And I was like, well, no, because there's not really a way. So I looked into it. How they do it in other states is like, it's a doctor that does, like, it's cash, right? So you go and you get a card. It's like $250, and you see them once a year, and they make sure you have the criteria set forth by the state about what you have to have. And then if you meet all that criteria, then you pay them $250. They give you a card that's good for a year. A year later, you come back and get it. So it's not somebody like me doing it. But I probably will have patients that once they do, they'll decide to go that route. And I'm fine with that. If they could do that, I think it's better than probably, we don't know the long-term risk of marijuana either, right? Because we just haven't studied it long enough. But I think that, you know, I think that it would be better for patients, honestly. I just don't know how feasible they're gonna be willing to stay on it. And like my friend, she was like, they have to use, and the gummies, interestingly enough too, like when you go to these, I've never gone to one of the stores, but I promise I have not. But
No judgment.
she was telling me that when you go in there, you ask these guys that are selling it and they tell you like, oh, do you want the okay stuff, or you want the good stuff, or you want the really good stuff? And you're like, so it's one of those things that you don't have, no physician is writing a dose like that. They are not writing, oh, you want the okay stuff for, no, they're just giving you the card. You go to the store and buy whatever you want. And so inevitably what happens is people are going to be like, oh, well, I mean, I don't want the really good, but I want the good. And then they take the stuff and then they're like seeing things, I just don't, I don't know. I wish it was more controlled. Like I wish that there was a way to control it more. Yeah, a dose. I'm a dose person, right? I got to have a dose. I wouldn't feel comfortable just taking something and be like, oh, well, they said it was the okay. I mean, okay, then may not be okay to me. So I'm just a dose person and there's no way to dose it.
So we have time for about a 5 to 10 minute break. If we want to do that now, would y'all like to do that now first before we go on? Well, thank you very much.
Thank you.
For coming. Appreciate you.
Anybody has any questions about anything, you're welcome to email me. I'll be happy to.
Please be
answer.
right back a few minutes before 9 o'clock so we can proceed.